Good morning. Thank you for joining us this morning. I'm Meghan Meyer. I'm a research nurse specialist in the Department of Leukemia at MD Anderson Cancer Center. I work in the MDS section under Dr. Garcia Monero. This morning, I'll be speaking on treatment options for elderly patients with MDS and AML. Here are our objectives for today. I'd like to discuss a brief overview of myelodysplastic syndromes and acute myeloid leukemia. I'll provide an overview of a risk stratification for these diseases. I'll explain the role of next-generation sequencing in the diagnosis, stratification, and treatment, as well as identify treatment options for elderly patients with MDS and AML. Myelodysplastic syndrome, or MDS, is a very heterogeneous group of myeloid disorders characterized by morphological evidence of dysplasia on bone marrow aspiration and biopsy. This disruption of cell lineage leads to peripheral blood cytopenias and associated anemia, infectious, and bleeding complications. As it is such a heterogeneous group of disorders, there are varying risks of progression to acute leukemia. MDS is primarily a disease of older adults with a median age at presentation of 70 years. It is relatively uncommon in patients under 50. These tend to be patients with underlying genetic disorders or those with prior chemotherapy earlier in life. MDS also occurs more frequently in males. Potential etiologies include environmental exposures to chemicals such as benzenes, pesticides, and organic solvents. Prior cytotoxic chemotherapy and radiation therapy also puts patients at risk for MDS. There are a few genetic disorders such as Fanconi anemia, dyskeratosis congenita, Diamond-Blackfan anemia, and Shwachman-Diamond syndrome that can lead to MDS, although this is mainly in pediatric patients. Prognosis of patients with MDS can be calculated using a number of scoring systems, and this is vital to determining the timing and choice of treatment options. The International Prognostic Scoring System, or IPSS, was initially developed in 1997, followed by the revised IPSS in 2012, which is now the most commonly accepted. Somatic mutations identified through next-generation sequencing can also help define prognosis and therapy in these patients. The original IPSS prognostic score includes three parameters: bone marrow blast percentage, number of cytopenias, and cytogenetics. This system stratifies patients into low and intermediate 1, which are considered lower risk, and intermediate 2 and high risk, which are considered higher risk. Mean survival in the absence of therapy ranges from 5.7 years in low-risk disease to around 5 months in high-risk disease. This system has been shown to be reproducible and additionally is very simple to use. Some limitations of this system, however, include that it is a less precise predictor of prognosis in patients with lower risk disease and attributes relatively little weight to cytogenetics. The 2012 IPSS-R scoring system expanded and refined the cytogenetic risk groups to 5 categories and includes more detailed cutoff points for cytopenias. Patients are stratified into very low, low, intermediate, high, and very high risk groups. While it's not as simple to remember as the IPSS categories, there are numerous online calculators and apps to assist in scoring patients using the IPSS-R. On the right, I've included the cytogenetic risk groups. Cytogenetic abnormalities, including deletion 5q or deletion 20q, confer a good risk, while deletion 7 or complex cytogenetics, meaning 3 or more abnormalities, confer a poor or very poor risk. You also score patients based on their bone marrow blast percentage, which, as you can see here, further divides lower blasts as compared to the original IPSS score. Patients with 2 to 4% blasts earn 1 point in the IPSS-R, whereas in the IPSS, blasts less than 5% added no points. Finally, you can use peripheral blood counts from the CBC to score patients based on their cytopenias and arrive at a risk score, which can help guide us in determining the best treatment options. One of the major advances in research in MDS has been the incorporation of next-generation sequencing assays. Identification of mutations allows for better understanding and prognostication of the disease, but also helps to design targeted approaches for patients with MDS. Mutations in genes such as RUNX1, TP53, or EZH2 have consistently been associated with an adverse prognosis, while mutations in the splicing factor, SF3B1, are associated with very favorable outcomes and prolonged survival. There are some therapies currently approved that are being studied in clinical trials that can target different mutations. Currently, the IPSS-R does not account for mutational status. However, a new molecular IPSS is expected in the future. Now that we can stratify their risk, how do we treat these patients? As MDS is a more prevalent disease in the older population, most of these therapies can be utilized in elderly patients, with the exception being allogeneic stem cell transplant, although some centers are transplanting older patients with a good performance status well into their 70s. This figure from Dr. Garcia-Manero illustrates treatment options based on risk status as well as age. Treatment of lower risk disease is typically driven by transfusion requirements. All patients should be receiving best supportive care, which may include transfusions, growth factors, and prophylactic antimicrobials. Iron chelation agents can be helpful in transfusion-dependent patients to reduce development of iron overload. Lenalidomide is utilized in a specific subset of patients, and Luspatercept was recently approved for patients with very low to intermediate risk MDS with ring sideroblasts, or MDS-MPN with ring sideroblasts and thrombocytosis. One of the most important areas of research is recognizing which low-risk patients may have a poorer prognosis and might require earlier therapy with hypomethylating agents. Lenalidomide, or Revlimid, is an oral immunomodulator agent used in the treatment of lower-risk MDS patients with anemia in the presence of deletion 5q. It can reduce transfusion burden in patients and may provide benefit to low-risk transfusion-independent patients to help delay transfusion requirements and change the natural history of the disease. This is currently being studied. Lenalidomide can cause significant thrombocytopenia and should not be used in patients with platelets counts less than 50,000. Other risks include thrombotic events and teratogenicity. Luspatercept was recently approved last spring. This is an erythroid maturation agent that is given subcutaneously every 3 weeks. It's currently approved for very low to intermediate risk patients with MDS ring sideroblasts or MDS-MPN with ring sideroblasts and thrombocytosis that require 2 or more red blood cell units over 8 weeks. Current studies are comparing Luspatercept to erythroid stimulating agents in lower risk disease and in combination with hypomethylating agents in higher risk disease. These patient guides from NCCN detail treatment recommendations for symptomatic anemia without deletion 5q utilizing growth factors, as well as recommendations for these lower risk patients without anemia who have thrombocytopenia, neutropenia, or increased marrowblasts that may benefit from hypomethylating agent treatment. As you can see, the current NCCN guidelines for treatment of higher risk MDS are quite limited: hypomethylating agent therapy or allogeneic stem cell transplant. It is for this reason that patients should be considered for clinical trials, if at all possible, for both frontline therapy, as well as for patients who have HMA failure. Hypomethylating agents are a group of drugs that can restore bone marrow function by blocking methyl groups from binding to DNA. This can turn back on genes that may have been silenced due to DNA methylation. They can be slower acting and can take up to 4 to 6 cycles to show response. These drugs can be very well tolerated by both younger and elderly patients alike, and the most common side effects being increased cytopenias and resulting effects such as fatigue, infection, bleeding risks, increased transfusion requirements, as well as constipation and nausea and vomiting. Cytopenias can be worse in the first several cycles of treatment, and frequent monitoring of blood counts in the initial cycles is important to establish a trend. Azacitidine, or Vidaza, was approved in 2004 and is currently approved for the treatment of all MDS subsets. Administration may be via IV or subcutaneous. It's generally given at a dose of 75 milligrams per meter squared for 7 days continuously, or may be given on a 5-2-2 schedule with a weekend break. Shorter dosing schedules are being evaluated in clinical trials. Decitabine was later developed in 2006, and it's indicated for the treatment of intermediate 1 risk disease and above. This is given IV only at this time for 5 days, and similar to azacitidine, shorter dosing schedules are being evaluated. Last summer, we received a very exciting approval of an oral decitabine cedazuridine combination, now called Inqov. The clinical trials focused heavily on pharmacokinetic data and found that oral decitabine and cedazuridine combo to have a virtually identical PK profile to IV decitabine. So this makes it a bioequivalent. And clinical trials are ongoing to evaluate this drug in lower doses for lower risk MDS, as well as in combination with other targeted agents. The development of oral decitabine is transformative in helping to shift the treatment of MDS patients to oral medications that are more easily administered. This slide from Dr. Garcia-Manero outlines some of the numerous targeted options that are being developed in clinical trials. These agents are typically combined with an HMA backbone, either azacitidine or decitabine. Some are oral agents, such as enasidenib or ivosidenib for treatment of IDH2 and IDH1 mutations, respectively. Venetoclax targets BCL2, and there are several oral FLT3 inhibitor agents. Clinical trials are ongoing utilizing the combination of anti-CD47 antibodies, such as magrolimab and ALX148. APR-246 and an oral version of that drug, APR-548, are currently being studied for TP53 mutated MDS. There's significant interest in these agents for the treatment of TP53 mutated MDS and AML, which remains very difficult to treat. Other targeted options include various immune checkpoint inhibitors targeting PD-L1, CTLA-4, and TIM-3 inhibitors. These are listed here. Moving on to acute myeloid leukemia, AML is a hematological malignancy characterized by greater than 20% blasts in the peripheral blood or bone marrow. The rapid growth of blasts lead to decreased blood cell production and cytopenias. Again, this is a disease most commonly occurring in older adults, with the median age at presentation being 68 years. Etiologies are similar to MDS, but also include antecedent hematologic disorders such as MDS, myelofibrosis, essential thrombocythemia, and polycythemia vera. The SEER data from 2021 reveals that AML accounts for approximately 1.1% of all new cancer cases in the US, with an estimated 5-year survival rate of 29.5%. The incidence of AML is higher in older adults, with nearly 60% of cases occurring in adults over 65 years and a third of all cases occurring in adults over 75 years. Improved treatment options for these patients are needed and are currently being extensively evaluated in clinical trials. Historically, the risk stratification in AML was based on age, performance status, and cytogenetic abnormalities. As you can see here, favorable risk cytogenetics include inversion 16 or transformation 821. Similarly to MDS, poor prognosis looking at karyotype includes chromosome 7 abnormalities and complex karyotype with 3 or more chromosomal abnormalities. With the development of next generation sequencing, we're now able to stratify patients based on genomics. Seen here is the updated 2017 European Leukemia Net risk stratification by genomics. Favorable risk genomics include mutated NPM1 without FLT3 ITD or with a FLT3 ITD that has a low allelic ratio, as well as CEBP alpha. Adverse risk genomic features include mutations in RUNX1, ASXL1, and of course TP53. This slide from Dr. Courtney DiNardo outlines the treatment algorithm for newly diagnosed patients with AML. Typically, elderly patients with AML are not eligible for intensive chemotherapy, so we will be focusing on the treatment options on the right in red. Elderly patients with AML are generally considered not fit for intensive chemotherapy due to age, in addition to potentially declining performance status and medical comorbidities. Today, I'm focusing on patients greater than 70 to 75 years old. Options for these patients include lower intensity chemotherapies such as hypomethylating agents, as we spoke about in MDS, or low-dose cytarabine. Combination therapy utilizing the BCL2 inhibitor Venetoclax with another HMA or low-dose cytarabine, as well as the combination of low-dose cytarabine plus Glasdegib are also options for these patients. Here are the NCCN guidelines for patients age 60 and older, which discuss induction and post-induction options for patients with and without actionable mutations. And you can see that FLT3 and IDH1 or 2 inhibitors are recommended in combination with HMA, either with or without Venetoclax. I'll speak briefly about some of the agents that can be used in combination, however, will not cover all of them due to limited time. Venetoclax or Venclexta is a small molecule inhibitor of BCL2. It was initially approved in 2018 for newly diagnosed patients with AML at least 75 years old who are not suitable for intensive induction chemotherapy. Patients should be assessed for tumor lysis syndrome risk based on tumor burden and comorbidities. Ramp-up dosing, prehydration, and antiuremics can mitigate the risk of TLS. Blood count should be monitored closely throughout treatment for hematologic and non-hematologic toxicities, and concurrent treatment with PGP inhibitors or strong or moderate CYP3A inhibitors can increase toxicity from Venetoclax and should be avoided. If they must be used, patients would need their Venetoclax dose reduced. Here are 2 options for combining Venetoclax with either an HMA or low-dose cytarabine. In the HMA arm, we use Venetoclax dosing at 400 milligrams daily for 28 days following a ramp-up. And in low-dose cytarabine, Venetoclax is dosed at 600 milligrams daily following a ramp-up. In November of 2018, we saw approval of Glasdegib or Daurismo in combination with low-dose cytarabine. This is a hedgehog pathway inhibitor that blocks the activities of hedgehog ligand surface receptors. It's an oral drug that's administered daily for 28 days in combination with low-dose cytarabine, which is dosed at 20 milligrams subcutaneously twice daily on days 1 through 10. Most common side effects were cytopenias, nausea, decreased appetite, constipation, rash, and musculoskeletal pain. And ivosidenib is a small molecule inhibitor of isocitrate dehydrogenase. It was approved in July of 2018 for treatment of adults with relapsed or refractory acute myeloid leukemia with susceptible IDH mutation. Later received approval for adults with newly diagnosed AML who are not suitable for intensive chemotherapy. It's an oral drug administered daily. And the greatest risk is of differentiation syndrome, which can be characterized as dyspnea, fever, weight gain, unexplained hypotension, kidney injury, pulmonary infiltrates, and it can be fatal if not treated. This, however, is mitigated with close monitoring and early appropriate treatment. I've included my references for your review. And thank you so much for your time this morning. I hope you found this information beneficial. I'm available for questions and have also included my contact information here.